On this episode of TLC Connections, we sit down with Tory Bright, Director of the Southeastern Regional Mental Health Services Coordination Office, to explore the state of community mental health across the region. Tory shares how her decades of experience, spanning crisis response, long-term care, and systems coordination, have shaped her commitment to strengthening public mental health services across southeastern Pennsylvania. This conversation highlights the importance of cross-system collaboration, community-based care, and compassionate leadership in addressing today's most pressing mental health challenges. We hope you enjoy the episode.
Welcome to TLC Connections, the podcast where educators, counselors, coaches, and community leaders come together to inspire change, one connection at a time.
Hello, and welcome to TLC Connections podcast. My name's Julie Knudsen, the Director of Development, and I am excited. I'm always excited about our guests, but to have Tory Bright here with us today. Tory is the Director of Southeastern Regional Mental Health, and I've known Tory for a long time, and we've crisscrossed, and she continues to almost be instrumental in my career in different stages, going way back to a forensic task force we were on. So welcome, Tory. Really glad to have you.
Yeah, thank you. Yeah. Thanks. I'm excited about being here.
So I just want to start with, if you can talk a little bit about your journey through mental health that ultimately led to this position that you have as director.
Okay. Well, I like to often introduce myself as I was born into mental health. I grew up in a family in the Montgomery County area, and we've had mental health struggles, addiction. I'm the youngest of 7 kids, and I was the caretaker, caregiver, person that people would come to for any kind of issues. Started my career straight out of Villanova, out of Montgomery County Community College, and then I had the opportunity to work for a number of different organizations in Montgomery County. First started at Crisis at the Montgomery County Emergency Services, and then I had the opportunity to work in case management services, and beginning of the case management, what they called the intensive case management program back in the 90s, and realized that there's a lot of people who were struggling, and there was a lot of administrative issues that were kind of barriers in the way. I probably, walked into too many hospitals and had too many issues that I said, something's not right here, and people are really, feeling a challenge with how to advocate for themselves as well as how to live safely in the community. So I've always worked with people who have serious and persistent mental illness. I think the history brought me to work for the county, Montgomery County Office of Behavioral Health. At the time, it's called the Office of Mental Health. And then I worked, the discussions started to happen around the state hospital downsizing. In Montgomery County, in this southeast region, we have utilized Norristown State Hospital. And I have had the opportunity for the last 23 years to be the director for the Southeast Regional Mental Health Services Coordination Office. So I cover all 5 counties and do all kinds of fun things with those counties. So
can you tell, now I appreciate that history that led you into this position. I didn't even realize it was 23 years that you have been with Southeastern Regional Mental Health. So what are some of the interesting challenges or experiences? What has been, the trajectory in these past 2 decades?
Well, I have 5 bosses. I work with the county administrators to, what we like to do is try and help improve the community mental health system, develop new services, and to really have a voice at the table with the persons who have lived experience to guide us. So individuals who have maybe been in the state hospital are now many of our colleagues and partners in the development of the system. So I'd say challenges. There's a lot of bureaucracy. There's not enough to go around. The demand far exceeds the capacity in terms of the services that we have and the people who have needs. And more so since we have really, in 2017, we closed the civil section of Norristown State Hospital, which at one point in time had over 1,000 individuals.
And I think that may be a misnomer. Norristown State Hospital, it's in Norristown, but it's not just for Norristown or Montgomery County.
Right. So Norristown State Hospital today actually is it's the regional forensic center for, I believe it's over 22 counties. And when I say forensics, it's for those individuals who have criminal justice involvement, who may have been have a mental illness, who are arrested, wind up needing treatment, or they need some evaluation to determine whether or not they're what we call competent to stand trial for their charges. And so the Norristown State Hospital has become what we used to have as a civil hospital, has now become the forensic regional center. There's 2 forensic centers in the state of Pennsylvania, one on the west side, that's Torrance State Hospital, and now Norristown State Hospital.
So that's it, the only 2
There's 2
institutions.
Yeah. And there are the evolution, and when you talk about the challenges, that has probably been some of the bigger challenges that we've faced, is that we have just so many individuals who are involved in the criminal justice system now.
So is it kind of an institution like state hospital, or is it, and I know there was, there's still the movement of community integration.
Yeah. So we continue to help people who go into a state hospital to focus on plans to help them move out. The one thing that I'd say is that while we closed the civil beds at Norristown, we were allocated 30 beds out at another state hospital in Wernersville, which is out in Berks County. So the 5 counties, for a population of 4.1 million adults, has 30 beds for the civil individuals who might need longer term treatment. That has become a challenge because when we talk about civil, these are individuals who don't have criminal justice involvement. Maybe it's a person who's wound up in the hospital, has really struggled to maintain their stability, and they need longer-term care. And we have some services in the community that provide those longer-term care needs, but we just don't have enough of the longer-term treatment care in the community. So folks who otherwise would have been at Norristown now go to Wernersville, but there's a significant lengthy wait list at Wernersville.
So you are instrumental or trying to be in all of it. I actually thought it was just people that had criminal involvement.
No, I actually, I sometimes term myself as kind of the person who assisted with the closing of Norristown State Hospital. And there's a lot of people who assisted with the closing of Norristown State Hospital civil beds. Part of the closing came as a result of a lawsuit, though, that was filed against the Department of Human Services by the ACLU. And it was it began around 2014. So that's, 10, 11 years ago. And that lawsuit was saying that there's too many people who are in jail, too many people who have mental health conditions, who have been arrested, are in jail, and they're not receiving treatment. And at the time the lawsuit was filed, there were over 150 people who were waiting for treatment.
While they were in jail?
While they were in jail. So the ACLU of Pennsylvania filed a lawsuit. That lawsuit kind of started to unravel some of the, as I say, the bureaucracy of the issues. And at the time, Norristown had a forensic unit, but it was a fairly small forensic unit. I think there were 125 beds. Now they have over 275 beds. There's always been a waiting list. There's people still waiting in jails. But the lawsuit did allow for the counties and the state to come together to develop some plans to be able to utilize resources that the state made available to develop new services in the community to help divert people from Norristown State Hospital, as well as to help individuals who otherwise would have remained in jail, and to be able to provide services to people who are in jail, or completely to look at the whole, what we call the intercept model, which is to divert people at a community level before they even become involved in the criminal justice system. So
you work at both ends.
I work definitely
All
at both
ends.
ends. I work at the front end of the system, and then I work at the back end of the system around the reentry. So
when you say someone's waiting in jail, I mean, meaning they've served their time, what is the barrier? What are they waiting for?
Well, they haven't necessarily served their time, because when a person who has a mental illness may get arrested for some type of an incident or action, they are being evaluated. And the goal is to evaluate that person to determine whether or not was the behavior as a result of their mental illness. Do they understand the criminal justice system process? Can they defend themselves? Can they use defense like public defenders and lawyers to help them during their incarceration and through the judicial system? So for a lot of people, that whole process gets paused because they have a mental illness.
So even determining should they be in jail? Are
Yes.
they, quote, guilty because
Yes.
did they know what they were doing?
Right.
Yeah.
So we might have individuals who go before judges, and because of their mental illness and they haven't had treatment for their mental illness, the judge might say, well, I think this person needs to be ordered for competency treatment. And competency treatment typically occurs in the state hospital. And that has always been the role of that forensic criminal justice portion of Norristown State. We are in the process throughout all the counties in Pennsylvania are working to try and develop new models. Can we do competency restoration in the community? Can we do competency restoration in jails? Are there step-down programs between a jail and a hospital that can do competency restoration? But all those take funding. And they take skill, they take staff, and that seems to be, a lot of the challenges. That's the bureaucracy that we're in.
Yeah, interesting. And I was going to ask if you had an unlimited budget.
No.
What would it look
No.
like? Beds would be one. Yeah,
if we had an
yes, I
unlimited
understand
budget.
you don't like. Yeah, well,
Well, an unlimited budget would do, again, front end work, shore up the infrastructure, the cracks that are in the system, and develop a lot more reentry services. I mean, we all agree, our Department of Corrections partners, our criminal justice partners, our county administrators, our legislators know that we are in need. I often find that many of these individuals were kind of lost before they kind of fell into the system. And
I think people with mental health in general,
and there's significant amounts of trauma. So there's significant amounts of trauma. There's significant trust issues of the system itself. So we're really fighting an uphill battle, even if we had all the money that we.
So what are some of the cracks? Can you speak to that?
Well, I think a crack right now. This has been kind of a struggle that we have. Again, we don't have sufficient number of long-term care beds. We're trying with our darndest to get to the people who, write the checks. But if the money's not there, the money's not there. To explain that when you have intensive care, what we call the flow in the system, you have people who are coming out of places. When we don't have enough of the supports for those individuals to move into, because the folks that are already in those types of services, those intensive care services, are not able to step down into other types of services because we just don't have enough of them, or the clinical supports aren't set up for that particular level of individual's need, we're going to get a logjam. We get a little bit, I call it, there's no off ramps.
Yeah.
The highways are completely full. There's a lot of traffic, and there's no off ramps for people to get to the next level of support. So we know resources are an issue. Funding is an issue. We've certainly seen more recently, we've seen programs say, if I have a vacancy in staffing, I'm not going to backfill it because there's no COLAs, there's no cost of living increases in some of the programs. And the counties, while they utilize blended funding, so we utilize Medicaid dollars, we utilize grants and different kind of what they call human services block grant funds, and they utilize through the Medicaid, there's health choices reinvestment funds. But if there's not enough to build to help create more off ramps.
Right. And sadly, then is one of the off ramp recidivism. I mean,
it's the recidivism. Yeah.
It's really sad.
So we've been doing some data projects with our counties to talk a little bit about kind of some of the best practices. And we recognize that the front door, the crisis system, the community system is really being paid attention to quite a lot these days throughout the country. Okay. We want to be able to have great crisis services. Some of the crisis services are working with law enforcement. We see a lot of co-responder programs. We're seeing CIT or CIS, crisis intervention training.
I just learned about the Veterans Response Team.
There's a
from
Veterans
Monco.
Response Team, which is fabulous.
Right.
And all counties are like hopping on this.
Yeah. Same with the co-responder.
Right.
I see people like to your point, getting on the front end, right? We all want to be proactive if we can. But the serious mental illness component is so complex.
Well, and I think that, one of the things I've been just learning recently in kind of doing some analysis of each county's crisis system, we want to look at data. We want to look at the outcomes, right? So 988 is this newest, brightest bulb in the area where I can call 988 and get some support.
The suicide prevention for people that are listening.
Yes.
Suicide crisis line. Yep.
So 988 has been around for just short of 2 years. And there's a lot of work that still needs to be done around that. We are going to all have to pay for it as citizens at some point in time. We're going to see our phone bills going up and whatnot. But the one thing that I recognize is that we're still kind of an old mindset of when I'm in trouble, I call 911 and police come. That's 911. Mm-hmm. Safety and secure, right? Make sure that the individual who they're responding to. So we have CIT officers, which is wonderful, which is the crisis intervention training that officers can take to work with people who have mental health problems and to work around crisis issues. But if a person reacts to law enforcement like it's their trigger, no pun intended.
Which is not uncommon. Right.
That person might actually get detained and then incarcerated or arrested and incarcerated. So I think we recognize that this continues to be a pathway where if 988 if I had a magic button and I'm a 911 call taker and I hear somebody's in a crisis and it sounds like it's a mental health, behavioral health crisis, I could click 988 and kind of have this digital process where mobile crisis could get dispatched, co-responders could get dispatched.
That's amazing. Yeah,
that would be the best opportunity, but we don't have that.
Because right now 988, I'm not saying just it's phone call. They're not dispatching anybody. That's a great idea.
Right. And not every county has the resources on a digital side or like a data warehouse.
Or the mobile response team like Monco has.
If Tory Bright is known in the mental health system as someone who might need some supports and I'm having a really bad day, really maybe the worst day of my life, and I call 911, that 911 doesn't know that Tory Bright's been in the mental health system. 988 in some of the counties might be able to connect to, Tori's got a little bit of a history here, so let's see about how we work with her to avoid and prevent any kind of, critical issues from happening. So everybody goes home at the end of the day in a good way.
Right. So to getting these two systems to talk would be an amazing starting point, at least. Yeah. I didn't even know that. I always learn from you. Your ability to collaborate and is honestly remarkable. Been honestly instrumental. I appreciate in my career, but working with different counties, working at a state level, from all angles. Right. I know if you can talk a little bit about mental health first aid and NAMI, and you just tackle this. I mean, you walk the walk. You live it.
Thanks. Yeah. I think I'm getting a little grayer every day, but I wear it well, I suppose. So.
For sure.
But I think so. A little bit about mental health first aid, because actually you and I kind of got to know each other during mental health first aid. My journey in mental health first aid. So this is a training program that's it's worldwide. It's in 27 different countries, and in the United States, mental health first aid came in 2010. I'd say yes, that's about right. 2010, and it's basically a public education program that is what I call pretty pedestrian. So it teaches people the art of noticing when somebody's having a struggle with a mental health problem and how to react, how to respond to that person.
Is it a different curriculum for juveniles? I know I did youth mental health first aid. Do you have it for youth?
So we have mental health first aid has a youth curriculum. So it's for adults who support youth. And then mental health first aid adult is for adults who support adults. And then there's all these various different specialty modules, they call them. So there's law enforcement, public safety, law enforcement, mental health first aid. There's older adult. There's college higher ed. There's veterans. There's rural, and then I think, I'm trying to think if there's a Spanish version. My office has a team of mental health first aid instructors.
So how does one access this? I know we did work together, and I worked in education to bring it to to the school district. If someone's listening or wants to learn more.
So we have a grant from Montgomery County Office of Behavioral Health, the Department of Human Services in Montgomery County, Health and Human Services actually. And we get the opportunity to provide 10 free trainings every year in Montgomery County. It's for anybody who lives, works, or supports someone who's in the county. We often are publicizing those trainings through our website and through Constant Contact and other distribution lists. If you go to www.5, spelled out FIVE, countymh.org, you can see where the trainings are being held.
That's great.
We've got, right now we've got some trainings coming up. We typically provide, it's a blended model of training. So there's 2 hours of pre-work that's done online. So a person can take their time in doing that. They do that, and then they come to the instructor-led portion of the training. And we found that going to people in the communities all throughout the county is the best way to do it. There are virtual trainings that you can take that are mental health first aid. But what we do is we're learning the act of how to provide mental health first aid to someone. So we go through scenarios, we learn signs and symptoms of someone who might be struggling, common mental health problems.
So you don't need a degree.
You don't need a degree.
Just an interest and compassion.
No. Yeah. And I'm telling you, we have so many testimonials that come back to us, people saying, I didn't realize that I was going to use it. And hey, I used the action plan of mental health first aid is called ALGAE. So I use ALGAE.
Yep.
I use ALGAE, and it actually worked. And
can you say that again? I should remember the acronym. I don't.
A stands for assess, or assess for suicide or self-harm. L is listen non-judgmentally. G is give reassurance and information. E is encourage appropriate professional help. And then the final E is encourage self-help and other support strategies. And it's not a linear process, because we're always really wanting to try and make sure that the person who we're mental health first aiding, that we're always assessing for safety. So, but it helps to teach people how to how to feel comfortable about how the conversation.
Yeah, and to ask some questions.
And
that you
to say, hey, I'm concerned
Yeah.
about you and I noticed this and, I'd like to try and help you. So we give out a lot of resource materials. We tell people, where to turn to. That information is often kind of the most rich piece.
Mm-hmm. And then, if you can talk a little bit about NAMI.
So the National Alliance for Mental Illness is an affiliate chapter here in Montgomery County, and we've been doing work with NAMI for years and years and years.
You served on the board, right?
I sat on their board for a number of years. No, I decided to dodge that responsibility for time management.
And I know you were recognized for an award recently.
So thank you.
Yeah.
So NAMI is a great organization. It's a support of it's a resource opportunity for people who want to share about what's happening in their personal world. It was originally designed as a family support group. I actually recall the first members of NAMI who sat around the kitchen table and said, hey, we'd like to create this support group. So that was many, many, many years ago.
Locally, but it's national.
Yeah, locally. Yeah.
Did it start here?
So, Kate and Ed LeBlanc were one of the first.
I didn't know that.
Yeah, back in like 1980, maybe 70 something. When I first started my career, I remember meeting the family, and I was like, "Wow, this is a pretty cool idea." But way back then, people were like, "It's not going to happen."
People aren't talking about it. Yeah.
NAMI is so rich in not only advocacy. Legislative kind of promoting what really works. NAMI has been at the forefront of helping to keep people out of the criminal justice system through CIT and endorsing CIT and helping to make that happen. I am a member. I have family members who have utilized NAMI. And I can say that, they just do a lot of good work. There's always somebody to talk to on the other side of the phone or in person. They do some educational programs, family to family. They have a program called In Our Own Voices. So they're doing a lot of work in the schools, which is really kind of cool because
you wouldn't have seen that 25, 30 years ago.
Right,
yeah.
Right. So, going into high schools and really kind of talking to students and staff and teachers about, okay, it's okay to not be okay. So let's talk about it. Let's open up the conversation. And that has been really a positive, that's been a major positive push with some of the work that we've done.
It's so interesting. So like you talked about, you are living all aspects of that, from prevention, from NAMI to mental health first aid, being in it, to the reentry, the people.
I remember when growing up, again, a little bit why I say I was born into mental health. My brother, who had a mental illness, really struggled. My family had no idea what to do. He went to the best schools. He was, in support. We had means to support him, but no one wanted to talk about it.
Even in your family?
In our family. And NAMI, that's kind of where I first came when I was in college. That's where I first came into contact with NAMI. And again, it was kind of I don't think that this is something that people want to talk about, but it was really needed. And
it sounds like it really helped you.
It's been such a grassroots.
Yeah.
Really.
So you maybe kind of answered it, but the Lincoln Center, we kind of talk about the butterfly effect, meaning one choice, one moment, one connection at a time can be life-changing, can be transformational. Mm-hmm. Can you think of a moment, a choice, a connection?
I have a lot of I think I'm more of, when I talk about the connections, I'm the type of person who I want to meet and know who I'm helping because it gives back to me. So I have been, for the last, 25, 35 years, there are people that I constantly go out and see because they're the people that at one point in time were over at Building 50 and now are living in the community. And now are doing well and have a job. So I have a 1:00 meeting with a gentleman today who I have known for probably 30 years. And he's taking one of our mental health first aid trainings. And he said, would you mind if I come and could you give me the one-to-one support to try and get through the blended portion of the training? Yes, because that's meaningful to me.
Yeah.
So,
and that's amazing. It literally keeps you grounded. I mean, from being a director and working at the state level, multi-county level, you're going to.
Yeah. I learned from the people who have the lived experience. Yeah. We all have it. We all carry, I'm going to use a term from from a colleague who I have worked with and done a lot of trainings with. We all carry invisible backpacks, and we never know what that invisible backpack has inside of it. No matter who you are, whether or not you're the CEO of an organization, whether or not you're a teacher, whether or not you're a family member or a person who's got lived experience. So so the way I look at it is we're all there. It's just a matter of how we connect. And I think that's what gives back to me is that I can make connections with people and feel like I'm doing something at the end of the day.
Yeah. So what's next for Tory Bright?
Well, there's still a little bit more work to be done. And, I'm hoping that retirement's around the corner, but, and I'm working right now on some projects with the Department of Corrections. I just got kind of assigned a project with the administrative offices of Pennsylvania courts to talk about how to teach some of the legislators and the folks from the judicial system a little bit more about why do we have best practices? Why are we have really good models here, but we're still having people come into our system and we're having a hard time diverting people. So that's a new one. That might take a year or two.
Right. Which really aligns that Lincoln Center's trying to get into the co-responder space. Yeah. And I think that's really aligns with that.
Again, when the one thing that I recognize is when we build things, they will come. We can't solve all of the public mental health system problems, but there are some things where we've certainly made major impacts. So if I were to retire today, or if I were to, say, okay, this is my last day, I think I've done a good job, but I know that there's still more work to be done. I enjoy a lot of things. I'm a very social person. I like to go out and be with friends and laugh and listen to live music.
Golfer, right?
And I like to golf, and I like to go out and be hiking, and I have dogs, and my youngest son's about to go off the payroll because he's about to graduate.
Congratulations.
Thank you.
Yeah. But I would imagine these things help keep you balanced through the hard work, what you see and do every day.
Yeah, you have to. Yeah. I think, everyone needs a wellness plan. And I realized a couple of years back that there's a lot of stress in this world. So when the doctor started prescribing some medication to me, I went, okay, that's not what I want to do.
Yeah.
So, but we all have to use the tools that we have. So I wound up, I have a wellness plan. I walk about 3 to 5 miles every day, take my dogs for a walk. I'm, typically outside every day, even in the rain and the snow.
Yeah.
I love music. I'm probably when I really do retire, I have this little band that's kind of this hippie band. So I'm going to try and see if we can and get some more stuff happening with this music. So,
but it's great advice for people listening as well. We talk about self-care, but being intentional, making a wellness plan.
Definitely.
You got to figure out what it is.
Yeah, definitely. So, it's been fun to see the system change. It actually has been a positive change, I'd say.
Well, you've been an integral part of it, and I know that you are more humble.
Yeah.
But like I said, going back in the day, it's been years that I remember sitting at the table with you literally at MCS at the Forensic Task Force and kind of look at where you are now.
Right. Well, I'm still here.
I know, but you and the strides and seeing, being in mental health, being a social worker, just seeing the recovery and how mental health is moving along in the right direction, people recognizing it, talking about it.
Yeah, I think the good thing is that we have a lot of good intention, and there's a lot of people who still are in this this journey to make the system better, and that partnership across all different systems is there.
I guess that's what keeps your passion, because
That's
you
what
can still
keeps it
feel,
going,
to not get burned out
Yeah.
doing such tough
Yeah,
work.
yeah. So we got still some work to do though. So
Well, Tory, thank you so much for joining us today. It's always great talking to you. I'm always learning something, and really genuinely appreciate your friendship and being a colleague.
Yeah.
So thank you
Julie,
so much.
thank you, and and very much back at you.
Thanks.
So we appreciate the work that the Lincoln Center's doing, and keep at it.
Thanks so much.
TLC Connections is supported in part by the Lincoln Center for Family and Youth. Through education, counseling, coaching, and consulting, we empower people to make positive choices, meaningful connections, and transformational change. To learn more, visit thelincolncenter.com.